Welcome, everyone. Thank you for joining us for today's track on systems pharmacology in designing precision therapeutics. It's my pleasure to introduce to you Dr. Adam Palmer, a systems biologist and a postdoctoral fellow with Peter Sorger in the Laboratory of Systems Pharmacology at Harvard Medical School. Dr. Palmer is working on the analysis and design of combination cancer therapies. He applies experiments, theory, and analysis of data from clinical trials of cancer therapies with a particular interest in the origins and therapeutic consequences of cell-to-cell and patient-to-patient heterogeneity in cancers. For a complete biography on our speaker, please visit the Biography tab at the top of your screen. Dr. Palmer's keynote presentation is titled The Impact of Patient-to-Patient Variability on Combination Cancer Therapy and Precision Oncology. My name is Judy O'Rourke, and I'll be your moderator for today's event. We are delighted to bring you this educational web seminar presented by LabRoots. LabRoots is the leading scientific social networking website and producer of educational virtual events and webinars. Before we begin, I'd like to remind everyone this event is interactive. We encourage you to participate by submitting as many questions as you want during the presentation. Simply click on the Ask a Question box located on the far left of your screen and type your questions into the drop-down box. Our speaker will respond to your questions via email following the presentation. If you have trouble seeing or hearing the presentation, please click on the Ask a Question box to let us know that you're experiencing a problem. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located in the top right corner of the presentation window and follow the process to obtain your credits. Now, without further ado, please join me in welcoming Dr. Adam Palmer. I will now turn the presentation over to him.
Thank you for the introduction, Judy. So I'm going to talk today about my research on patient-to-patient variability in combination cancer therapy and discuss the implications of this work for precision medicine in oncology. So most cancers are treated with combinations of multiple cancer therapies because they are observed in clinical trials to improve patients' chances of survival. So it's illustrated in this picture here, for example, is we have a cancer cell which is being treated with 2 or sometimes more therapies acting on different targets. And what is in many cases observed, but not for all combinations, but for some combinations, that the use of those multiple therapies can improve patients' odds of survival. And there's a multitude of reasons why different combinations of drugs can have this beneficial effect on patient survival. The first issue to consider is that the drugs might act upon pathways that have some functional interaction, or the activity of one drug upon the cell might change the way the cell responds to a second drug. And ideally, that could enhance its activity and give rise to a synergistic killing of the cancer cell. A different issue to consider is that within any cancer is a collection of genetically and phenotypically heterogeneous cells, and those cells might vary in their degree of sensitivity to each of 2 drugs. And finally, when it comes to a human clinical trial, one will observe a still greater degree of heterogeneity among different patients' tumors in their degree of responsiveness to each of the different drugs within a combination. And this is most clearly observed in clinical trial results themselves, where, for example, if you look at the survival distribution colored in red there of patients treated with just one therapy, you'll see there is some percentage of patients out on the far right-hand side of the survival curve where that treatment has been very effective for them. And there will be other patients with nominally the same type of cancer receiving the same therapy for whom the treatment is not very effective and rapidly fails. So from this view, then, we can understand 3 general rationales for combining cancer therapies. The first being that the drugs could give rise to an additive or synergistic effect that could be more effective at killing every individual cell within a cancer. Secondly, combinations of multiple drugs could be effective at overcoming the clonal heterogeneity that exists within a cancer. And this mechanism could be as simple as that some fraction of the cells are resistant to drug A and they can instead be killed by a different drug B that acts via a different mechanism of action. And finally, the same logic can also play out at the scale of patient-to-patient variability, that in a collection of patients treated with therapies, Some of them might respond well to drug A, some of them might be resistant to drug A, and among those who don't benefit from drug A, some of them might instead benefit from a different drug B. The historical rationale for using combinations of cancer therapies, if you go back and read papers from the 1940s and 1950s about why we should use combinations of drugs, it was very much inspired by the success of combination therapy at eradicating tuberculosis and the concept that it was overcoming clonal heterogeneity and defeating the evolution of drug resistance. So that's the scenario in the center here. Today, with a molecular understanding of cancer, there is a more dominant emphasis on understanding interactions among drugs and cases where we could achieve synergistic killing of cancer cells with combination therapies. What I'm going to talk mostly about today is the scenario on the right-hand side, the role of patient-to-patient variability in responsiveness to different cancer therapies. And the significance of this phenomenon became apparent in some of the earliest human clinical trials of combination therapies for cancer. So this data comes from 1961 when the acute leukemia group B was testing different combinations of anti-leukemia therapies in children with acute lymphocytic leukemia. And what they observed in one of these trials was that they could achieve about a 25% rate of remission among patients treated with mercaptopurine. They could also achieve about a 25% rate of remission among patients treated with methotrexate. And if they treated those patients with both drugs at the same time, there was a substantially higher rate of remission. So one possible interpretation of this is that the two drugs are more effectively killing the cancer cells in individuals, and there's some fraction of patients who do not benefit from either single agent, but who do benefit from the both mixed together. However, this trial was a crossover trial where there was 3 different arms investigated. First, patients could receive methotrexate, and when that eventually failed, they could swap over to mercaptopurine, or they could be treated with mercaptopurine and then swap to methotrexate, or receive both at the same time. And what they observed in this crossover was that among the patients who, say, did not respond to mercaptopurine, if they were treated with methotrexate, that succeeded about 25% of the time. The patients who did benefit from mercaptopurine and had a remission, well, when that remission eventually gave way to a relapse, if they were then treated with methotrexate, again, it succeeded about 25% of the time. So it was clear that the activity of the different drugs were not overlapping on the same individuals. And that gave rise to this understanding of population structure illustrated in this grid here, where you have among the group of patients laid out in that square, there's some chance of response to mercaptopurine and some separate chance of response to methotrexate. And those chances do overlap as much as you would expect by random chance. But then the benefit of the combination therapy can be calculated. Simply the response rate, or RR in this equation here, the response rate to drug A plus B is the response rate to drug A plus the fraction of patients who don't benefit from that might respond to the second drug just based on the degree of activity that that displays all by itself. And what they found over a series of trials of different drug combinations was that every way they had of combining mercaptopurine, methotrexate, prednisone, and vincristine, always the remission rates for the drug combinations were fairly predictable based upon the activities of the single agents. And what they concluded from that was that the data suggests that the advantage derives from the two drugs acting independently on the patient. So coming back to this illustration of different rationales for combination therapy, what's very interesting about this phenomenon of between tumor heterogeneity is that it makes a quantitative prediction of how much activity the combination therapy should exhibit based upon the single drug activities. Now, this is a baseline level of benefit that occurs before there is any stronger benefit of the matter of overcoming heterogeneity within individual patients' tumors or having synergistic effects on individual cancer cells. So we can say what's being predicted here is what's the bare minimum benefit that is obtained simply because you have two differently active drugs. So that phenomenon was understood at some level as of 1965. And for reasons that I can only speculate about, it was largely overlooked in the remaining 50 years. And so I'll present now my analysis of how this phenomenon applies to contemporary clinical trials data. So the first thing to present here is the nature of clinical trials data today. It's no longer evaluated on something as simple as response rate, but rather distributions of survival times. So this is an example of a survival function where the vertical axis shows the percentage of patients whose tumors are under control, or a phenomenon known as progression-free survival. And as time goes by on treatment, more and more patients have their tumor develop resistance to the therapy and start to continue growing. And every time the patient's tumor grows, that curve goes down some amount. So the underlying data behind these clinical trials is rarely, if never, published. And so what was necessary to perform an analysis of this data first was to use image processing algorithms to digitally trace these curves and extract the data. And so what I developed was a pipeline where one could go from a published clinical trial figure, for example, in the New England Journal of Medicine, and apply image processing to extract digitized survival distributions. And there are hyperlinks at the bottom of the slide here where you can download the software that I use to perform this. It consists of Mathematica scripts. So the first example of a trial that we'll analyze here is combination immunotherapy for the treatment of metastatic melanoma. Now, this particular plot here is a curve of distributions of patients' tumor volume changes. So this could be understood as a series of bar charts, in fact, but which have been collapsed to a single line. So you could imagine a series of columns that are every individual patient. And here we're showing these sets of data for different treatment regimes, where the lower the curve is, the better. That's more patients have more tumor shrinkage. And we see in pink the responses to the immunotherapy ipilimumab, and that produces tumor shrinkage in about a third of the patients. And in green is responses to nivolumab, which produces tumor shrinkage in a little over 50% of patients. And in blue is the observed activity of the combination of both therapies, which achieves tumor shrinkage in a higher fraction of patients than any single drug. So the simulation of what these drugs should do in combination under this model of purely independent activity consists of, for each patient, randomly sampling a response from the ipilimumab distribution, then randomly sampling a response from the nivolumab distribution, and choosing the better one of the two single drugs. And this is then repeated to simulate a distribution of responses across patients, and that produces the line shown in black. And what you can observe here is that the superior activity of the combination therapy is very close to what is predicted under this model of drug independence. We can perform the same analysis on the progression-free survival data, showing how long patients' tumors are under control. And I'll explain here a different, simpler way to perform the analysis if you are working with progression-free survival distributions. So what we can apply here is to take the equation that I presented earlier and adapt that equation for the application of DFS, progression-free survival. So the expected survival distribution for a combination of drugs A and B is, well, it's at least as good as the survival distribution for drug A alone, plus the fraction of patients who do not respond to drug A might respond to drug B. And this particular calculation, in fact, slightly overestimates the observed activity of the combination therapy. And so what was missing here was an accounting for cross-resistance between the drugs, which can be captured in this equation with a correlation parameter rho. So what's being described here by this correlation or cross-resistance is that the patients who are resistant to drug A might have a worse than average chance of being resistant to drug B. And in this particular clinical trial, we see in this curve in black here that the best fit to this clinical data is obtained by assuming a partial positive degree of correlation, so a partial degree of cross-resistance, and that's consistent with what's clinically observed in crossover trials of these therapies. That if, for example, you take a patient who has failed to respond to ipilimumab and treat them afterwards with nivolumab, it has a slightly lower rate of response, but certainly not a zero rate of response. So overall, in the activity of this combination therapy, it's a superior treatment in terms of efficacy. It improves patients' odds of survival, and that benefit can be explained by patients each receiving their best single-agent response. So there doesn't appear evidence that the drugs are adding up to a stronger effect in individuals. but rather they have a benefit at the population level because of differences among individuals in who responds best to ipilimumab or who responds best to nivolumab. So what this illustrates is that the one parameter here, the one free parameter, is the cross-resistance between the drugs. If drug A is working or not working for you, what does that mean about the chance of activity from drug B? And ideally, what we would like to know is, for the same patient, how would they respond if they received drug B, and how would they instead respond had they received drug A? And it's not possible to gain that insight from a human clinical trial where different patients are assorted to receiving different treatments. But it is possible to obtain this insight using patient-derived tumor xenografts. This is a setting where you can take a single patient's tumor and implant it into multiple mice that then receive different treatments. And you could see, for example, if some fraction of the tumors that are treated with drug A or drug B respond to therapy, as illustrated in red here, you can ask, is it the same tumors that are responding to the different treatments, or is it different sets of tumors that are responding to the different treatments? The largest set of data of this type that I was able to analyze came from Novartis, who has developed a library of patient-derived tumor xenografts, and in this article by Hui Gao, published in 2015 in Nature Medicine, they released full underlying data for 230, slightly more than that, xenograft models across 6 different types of cancers treated with a variety of different single agents and combinations of therapies. So I mined all of this data to look at the correlations between different drugs. And what is observed in this data is the general trend is one of partial positive correlation. So resistance to drug A tends to be bad news for the chance of response to drug B, but there is a lot of heterogeneity in there. The correlations are higher if you look at drugs acting on the same pathway, and they can be a little bit lower than average if you're looking at drugs with clearly different mechanisms of action, for example, comparing a cytotoxic chemotherapy or a targeted inhibitor of oncogenic signaling. The therapeutic implication of this low correlation or differences among who responds best to which drug is nicely illustrated by this data, which comes from gastric cancer xenografts treated with a PI3 kinase inhibitor, illustrated in green, or an antibody drug conjugate against FGFR, illustrated in purple. And you see that the better drug on average is the kinase inhibitor, and the antibody therapy is, for about 80% of the tumors, is no better than untreated, and only in a subset is it highly active. Now, it might look on this survival curve that in that 20% subset responding that there is a similar degree of response to the kinase inhibitor or the antibody therapy. This is, in a sense, an optical illusion of survival curves, that the longest responses are in the bottom part of the curve, but they're not necessarily in the same individuals. Now, if this were a human clinical trial, you wouldn't be able to know it, but because it's xenografts, we could instead plot this as bar charts and look side by side for each individual tumor. How does that single tumor respond to each of the 2 different therapies? And what we see here is that the antibody in purple is producing some very strong responses in a number of tumors that are not responding particularly well to the kinase inhibitor in green. So if these therapies were combined and each individual's tumor's response to the 2 of them was just the best single agent response, you would still expect to see a significant improvement in the survival function, illustrated here in black. So what this data shows is that simply because different tumors can respond best to different therapies, combinations of therapies can improve response rates even without any additivity between the drugs. A different insight that can be obtained from looking through this large cohort xenograft data is to see more broadly the way in which drug combinations are beneficial by overcoming our inability to predict the best personalized treatment. So we can ask, given this data, for every xenograft, what is its average response to a single drug? And what is its average response to one of the combinations of drugs that it was treated with? And you see in these survival functions in green and blue that on average, combination therapies are superior to monotherapies. But if we go through this data and for each xenograft, choose random pairs of monotherapies and select the best single one of those 2 responses, the response distribution to these random pairs of monotherapies is almost as good as what is observed for the average responses to combinations. Now, this certainly does not mean that we should treat cancers with random pairs of drugs, because certainly the average response to therapies is not as good as the best response to a particular therapy for a particular tumor type. We can use this data to apply in a retrospective sense the extreme form of personalized therapy, that we can look amongst the 20 or so different therapies that each tumor received, what was the single best response it had to any single drug? And what was the one best response that tumor had to any particular combination therapy? And if we go across all 230 xenografts and plot the survival distribution for their responses to the absolute best single drug or the absolute best combination therapy, well, first, you can certainly see this is much better than the average responses to therapies. But comparing the best retrospective monotherapy or the best retrospective combination, they look very similar to one another. So this shows that broadly across this data, if you knew how to choose the best single drug for each individual, there would not be such a strong need for combination therapies in these cases. The benefit of combination therapies on average stems from the fact that in practice, it is very difficult to know what is going to be best for an individual. It's also worth noting these were all models of metastatic solid tumors, and the scenario among the benefits of combination therapies can be quite different in leukemias and lymphomas that I'll briefly note at the end. So this data from xenografts is very interesting, but ultimately what matters is how this phenomenon plays out in human clinical trial data. So this slide now shows the application of this analysis to a variety of human clinical trials of combination therapies across a variety of advanced solid cancers. And what we're doing here is taking responses to different individual treatments in green and purple and applying this equation to calculate the expected effect of the combination therapy under this model of independence, or more specifically, really, a model of the best single agent response in every individual patient. And now we can compare this prediction in black to the observed effect in the clinical trial data of the combination therapy shown in blue. And what we see then on the bottom in the cases marked by red stars are some cases where the observed activity of the combination therapy in blue is substantially superior to the predicted effect of the combination. So here then are cases where the two drugs are genuinely achieving a stronger response in individual patients. For example, on the bottom left and bottom center in ovarian and colorectal cancers, these are both trials combining the angiogenesis inhibitor bevacizumab with a cocktail of other cytotoxic chemotherapies. And what we understand in these cases is that the application of an angiogenesis inhibitor normalizes the tumor vasculature and improves the delivery of chemotherapy to the tumor. Conversely, in the cases in the top two rows, we can see that the activity of the combination therapy does not seem to be exhibiting any degree of synergistic activity inside human patients treated with these therapies. That doesn't rule out that there are mechanisms of interactions between the drugs. There could be all sorts of molecular interactions between the drug's effects, but they don't have a substantial benefit in terms of the duration of tumor control. One case worth noting is in BRAF mutant metastatic melanoma treated with dabrafenib and trametinib. In that case, one of the major clinical benefits of combining those is that trametinib diminishes some of the skin toxicity caused by dabrafenib. But in terms of the efficacy of tumor control, it does not surpass the prediction of independent action. Now, no part of this analysis changes the original conclusions of the clinical trials that these are combination therapies that significantly improve patients' odds of survival. But it changes our understanding of the mechanism of why it is that they are beneficial. They do not necessarily need to have synergistic interactions between drugs, but rather it can be beneficial to combine drugs simply in the case where some set of patients will benefit well from drug A, some set of patients will benefit well from drug B, but if we don't know who should get which one, then the patient's odds of a strong response is improved if they receive both. This is very much a call for further improvement of precision methods very broadly across oncology. There are some important limitations to note in this analysis. First, it's very important in these calculations that we're only comparing trials where the dosages of the drugs or the dosing regimens were identical or very similar between the monotherapy and the combination therapy arms. And that has been the case for the clinical trials that I presented here, that if there were dose differences, they were very minor or temporary changes in dosage. More broadly across oncology, there are lots of trials where there are substantial changes in dosage in the combination therapy arm, and that would make it difficult to apply this analysis. It doesn't mean that the phenomenon that patient-to-patient variability plays a role in the benefit of the combination therapy. I believe the phenomenon could apply very broadly, but it becomes difficult in these cases to calculate what sort of benefit of that phenomenon you would expect if we do not know how a dose change alters the efficacy of one particular ingredient in a combination therapy. The second limitation is that the correlation in drug response, or the cross-resistance between drugs, is a very important parameter, and there's not a whole lot of data on that. So for the purpose of the data that I presented here, we made use of the response correlations as they were observed in the patient-derived tumor xenografts. It generally varied between 0.1 and 0.5. Sometimes this data can be obtained from clinical trials, in particular crossover trials where patients receive treatment A and then switch to receiving treatment B after it fails. And so, for example, in this data illustrated here, looking at pemetrexed and crizotinib responses in lung cancers, we can see here that there is no correlation between the activity of this chemotherapy or targeted therapy. But this sort of data is hard to come by. Another limitation is that if the responses to multiple drugs really are going to add up to something stronger, it's likely to be in that set of patients where both drugs are active, both are delivering some substantial degree of tumor cell killing, and you might see much more killing when they're both present. So the circle illustrated in purple on that little grid of patients on the bottom right. And often in human clinical trial data, the follow-up might not be long enough to track those survival curves all the way down to zero. And so it might be in some cases that the fraction of patients who really respond best to each of those two drugs, there may or may not be an additive or synergistic effect there. And the clinical trial data sometimes is simply not able to give an answer to that question. Finally, there were some cases where it is possible to find a clinical trial that tested treatment A alone, treatment B alone, and treatment A combined with B. That's the ideal sort of data to work with. Often, though, it is the case that a clinical trial would test treatment A plus or minus treatment B without having data on treatment B by itself. And in those cases, it may be necessary to make the best available insight will come from a cross-trial comparison. And if that's going to happen, it's absolutely vital to make sure that the patient enrollment criteria are really very closely aligned in terms of the exact types and stages of cancer and what sorts of pre-treatment they have received. Otherwise, one could draw very invalid conclusions from comparing trials that aren't the same sorts of patients. One of the other applications of this model of drug independence is that it can be applied to forecast the efficacy of combination therapies based upon monotherapy data. Now, as you'll see in the top left here, this is not a model that predicts that all combinations of therapies are going to be beneficial. For example, when looking at responses to crizotinib or docetaxel in ALK-rearranged lung cancer, we wouldn't expect very much benefit of adding docetaxel to crizotinib, ultimately because crizotinib is so much of a stronger therapy that that's typically going to be the best thing for everybody as compared to docetaxel. In other cases, for example, in BRAF mutant melanoma, one would expect that simply because the BRAF inhibitor dabrafenib and the immune checkpoint inhibitor nivolumab, each of those have a pretty substantial chance of producing a durable response to therapy in patients. Having those two substantial chances of durable response can be expected to give rise to a fairly significant improvement in the odds of survival, even if there was not any form of additive or synergistic interaction among the two therapies. And going through all of the different drug response data in Novartis's xenografts, only 5% of combinations were predicted to surpass the best monotherapy for that tumor type. Often the reason that happened would be that even if drug A plus B were going to be better together than either one alone, there might be some other drug X, which is a far superior, more active agent for that tumor type. And that gives rise to the phenomenon where many sorts of combinations just do not surpass the best single therapy for that tumor. None of this is an argument against finding synergistic combinations. We can see in human clinical trials and we can see in xenograft data some set of combinations which really do give rise to substantial synergistic effects. And that's illustrated in this example of xenografts of melanoma here, where if they're treated with a combination of the CDK inhibitor ribociclib and the MEK inhibitor binimetinib, that combination showed a vastly superior response to the prediction of independent action. And among the clinical trials that we looked at, many of them were beneficial and approved combinations even without synergistic effects. So if these sorts of large synergistic interactions could translate into human trial successes in the future, we could see some really beneficial responses to combination therapies if we can find the right sets of drugs and the right patient populations where synergistic interactions will truly occur. There is, though, some cause for caution here, and I need to be very careful about how we measure synergy in preclinical settings, because in most of the clinical trials that I presented, there were experiments in cell lines or mouse models that did show evidence of synergistic interactions, which somehow did not manifest in the human clinical trial data. One example of this comes from experiments in colorectal cancer cell lines treated with cetuximab and oxaliplatin. Now, in cell lines, they showed a very strong degree of synergistic effect, a combination index of 0.1, meaning the combination was 10 times more potent in a dose-response function than the single agents. And when that cell line that showed a synergistic interaction was implanted into a mouse xenograft, the combination of the therapy illustrated in blue, the blue growth curve here on the right, was far superior to the activity of either of the single agents shown in yellow and red. Now, if we compare the activity of this combination therapy in human clinical trials in KRAS wild-type colorectal cancer, we can see on the bottom right-hand side here a curve in pink which shows the survival benefit of treating patients with cetuximab monotherapy in the case of patients whose cancer was refractory to chemotherapy. So after chemotherapy failed, they received cetuximab by itself, and this provided some improvement to survival. Cetuximab was then tested in much larger clinical trials, combining it with cocktails of cytotoxic chemotherapies, including fluorouracil combined with irinotecan or oxaliplatin. And what's observed there was the benefit shown in blue as compared to the survival curve in green. If we take that shaded pink area, which is the magnitude of survival improvement conferred by cetuximab, and map that on to the baseline survival function of chemotherapy only in green, that makes a prediction, the line shown there in black, the simulated combination of just adding on the benefit of cetuximab monotherapy. And you can see that that modeled line in black fully accounts for the clinical benefits of the combination shown in blue, which shows that, yes, cetuximab did improve patients' duration of survival, but it improved it to the same degree whether you give it by itself or if you combine it with chemotherapy. So it helps, but it's very clear in the human data that there is no synergistic interaction between the drugs, even though in the mouse model data and in the cell line data, it appeared to be spectacularly superior when they were combined as compared to when they were used as single agents. There are a number of possible explanations why it might be that synergy in the preclinical setting has a hard time translating into the clinical setting. Some of this might lie in pharmacokinetic variability, or if synergy is very susceptible to genetic background or issues of experimental design. But I think the heterogeneity of patient populations or the heterogeneity of tumors may itself be one of the major parts of the problem. And that's illustrated in the schematic here, where every circle represents a tumor, and they are shaded in blue or red in proportion to their strength of response to each of two drugs. And And what you see in this scenario is that the majority of the tumors are responding either to neither therapy, or the response is largely dominated by one or the other drug. There may be some fraction of patients who respond very strongly to both drugs, and this might be that bottom part of the survival curve where it is difficult to quantify the benefit of the combination therapy. And if synergy is going to be observable in a clinical setting, it may be most evident in this middle scenario, this territory where each of two therapies are giving some partial response and together they add up to more. And this is the sort of scenario that one tends to investigate in a preclinical experiment, partial inhibitory doses of two drugs, as was illustrated in that previous slide looking at oxaliplatin combined with cetuximab. So I think what this view of heterogeneity in the patient population suggests is that even if mechanisms of interaction between drugs that give rise to synergistic killing of cancer cells, even if they occur in human populations in clinical trials, it might manifest in a meaningful way in only a minority of the patient population that might be statistically difficult to detect in a clinical trial. Now, ultimately, this is a call for greater precision in knowing who needs one or the other single drugs, or which subsets of patients, if any, are truly going to have a synergistic benefit from a combination therapy. This understanding of patient-to-patient variability in drug response also has implications for how we evaluate different single therapies. And that's nicely illustrated by this data from pancreatic tumor xenografts treated with a chemotherapy gemcitabine in green, or a MEK inhibitor, binimetinib, in purple. And what we see here is if you look at the survival functions for these two different modes of treatment, there's no difference between the two of them. And one might look at that and think that there isn't a role for the kinase inhibitor as compared to the standard chemotherapy agent because it's no better. But when we look at how the individual tumors respond to each of the two therapies, we can see that there is some subset of the tumors for whom binimetinib is a superior treatment option, and some other subset that do not respond very well to that kinase inhibitor and for whom the chemotherapy gemcitabine is the superior treatment option. So a clinical trial that might be deemed a failure because there's no difference between the activity of two drugs, really all it's telling you is that there's no difference between the two on average. And what's best for patients on average can be very different from what's best for the individual. And if we were able to find biomarkers to identify the subsets of patients who are more responsive to one or the other, then we could find defined patient subsets for whom a new therapy is really a superior treatment option, even though it might not be better on average. So the conclusions then are that drug combinations give each patient more chances to receive at least one personally effective drug. This is not the only cause of benefit of combination therapy, but it can be a substantial cause of benefit when cross-resistance between drugs are low and when they have a significant degree of activity in some fraction of the patient population. So I've described a drug independence model with an equation that's easy for other people to apply for the analysis of clinical trials data. And this can look at clinical trial data comparing monotherapies to combination therapies to identify cases where combination therapies really do have an additive or synergistic effect. This sort of analysis could be applied in a biomarker stratified fashion to find if in a subset of patients it's consistent with independent benefit, and if in some other subset of patients we might see evidence of synergistic activity. And it can also be applied to the analysis of monotherapy data to estimate the activity of novel drug combinations under an assumption of no drug-drug interactions. Now, in practice, sometimes there will be antagonistic or synergistic effects between drugs and combinations, but this provides an estimate of the likely magnitude of activity, which empirically is often rather accurate. And what this means for the future of cancer therapy is that combinations which are beneficial for reasons other than having an additive or synergistic interaction, if it's really just about a bet hedging type of benefit at the population scale, those sorts of combinations have the potential to be replaced by a biomarker stratified choice of treatment, or alternatively, a sequential use of the treatments. Whether this sort of approach is desirable as compared to the combination therapy would depend upon the degree of toxicity of the combination therapies, and it would depend upon our ability to actually identify some sort of biomarker identifying who respond to which particular therapy. So I mentioned things play out very differently in leukemias and lymphomas. So those are cancer types, as well as a few cases of solid tumors where cures can be obtained in a large fraction of patients with combination therapy. Now, monotherapy treatments are almost never curative of advanced cancers, and so it's very clearly the case in any combination therapy that can achieve cures of patients, the combinations of drugs simply must be adding up to something more than the best single agent activity in this fraction of patients illustrated in the purple box here, for example. So it's not the topic of today's seminar, but if you're interested in reading more about this phenomenon, I've included a link here to a preprint on bioRxiv studying a 5-drug combination therapy called R-CHOP, which has been used for about 20 years now to cure a majority of patients with diffuse large B-cell lymphoma. And what we observe in that particular study performed by myself, Christopher Chidley, and Peter Sorger is that the combinations of multiple independently active therapies, they tend to add up in a fairly predictable manner. For example, if drug A kills 99% of the cancer cells and drug B kills 99% of the cancer cells, the combination will kill 99.99% of the cancer cells if they are subject to different resistance mechanisms. So I'll indulge in a little bit of speculation here to think about what this means for the design of combination therapies and what this means for the role of precision medicine in oncology. So from the data that I've presented, the picture that emerges is that different drugs have different degrees of activity across different patients. That's illustrated here with these different lengths of arrows. And their effects in combinations, if they are mechanistically independent drugs that kill cancer cells in different ways, then their effects in combination tends to be fairly predictable. So what does this mean for how to design combination therapies? Well, one of the approaches that has been pursued historically was the method developed by Donald Pinkel for the treatment of childhood acute leukemia, where I started this seminar with data from 1961, where when they sort of moved beyond 2-drug combinations to 4 or 5 or 6 or 7-drug combination therapies, they pursued this approach called total therapy, which really meant using all the drugs for all the patients. And if that is tolerable for people, yes, you can achieve a far stronger degree of cancer cell killing. But given this view that what we know is that every single drug is active in some patients and inactive in other patients, I think that what's occurring with combination therapies like this is that you could have drugs used in the combination where in many of the patients they don't particularly need it, and there is some degree of bet hedging going on with the use of lots and lots of drugs increases the probability that you will have many of them that are active in each individual. And it suggests that it's not necessary to give all of the drugs to all of the patients if you know which ones would be most active in which patient. So I think what this suggests is the approach to design the best combination therapies would depend upon choosing the ingredients of those combinations with precision to treat each patient with the drugs that are most highly active at killing their particular cancer and minimize unnecessary toxicity. Now, this is a very tough scientific challenge, and it's a very tough practical clinical challenge. If this was delving into a space of many novel combination therapies, some random selection of them could have unpredictable toxicities when delivered in combinations. What I believe might be a more practically achievable goal in the near term could be described as personalized consolidation of a standard first-line therapy, where perhaps patients receive as a current matter of course a combination of 3 drugs, A, B, C, and rather than pursuing an approach where we take one other new therapy and combine that with A and B and C for all of the patients, rather among the set of therapies that we have, we try to find which will be most active for each individual. So apply the methods of precision medicine to know for each individual what other therapy is going to be best for them and make that part of the combination therapy that they receive. So again, to repeat the final conclusion here, I think the best drug combinations are going to be made by selecting the ingredients with precision. So ultimately, the challenges of combination therapy for cancer and precision therapy for cancer, I think, are interlinked challenges. So I'd like to thank my advisor, Peter Sorger, and my co-author on the work in lymphoma, Christopher Chidley, and a variety of clinicians and scientists whose discussions made this work possible. Data on xenografts from Novartis, which was published and made available to everybody, and funding agencies. Thank you very much, and I hope to answer some of your questions online. Thank you.
Thank you, Dr. Palmer, for that informative presentation. I would also like to thank LabRoots for making today's educational webcast possible. As a final reminder, our speaker will follow up with any questions you've submitted via email. That is all for now. Thank you for joining us. We'll see you next time. Goodbye.